Hello everyone and welcome back. Today we'll be going over a case where I do both the root canal and an apico. In this case you can see very large apical finding at the root of this tooth. They had started the root canal a few years prior. This patient's pretty young, she's only 19 at the time of the treatment here. She had some decent swelling, and if we look at the cone beam, you can see I've measured a few different things on here as far as the length of the tooth, but look at the size of the lesion there, 22.8 by 12.5, and then when we go into the other angle there you can see we're at almost 11 millimeters. It's very easy to figure out the volume, and that turns out to be 3,181 millimeters cubed, so very large. So what does the literature have to say about the size of the finding on the cone beam and what will happen? So let's first review article here from 2023 that looks at the association between the clinical and radiographic characteristics and histopathological diagnoses of periapical granulomas and cysts. If we jump straight to the conclusions here, what you see is that the number one consideration here is if the lesion involved multiple teeth, it had a 6 times more likely chance of being a periapical cyst. This one was large enough that it did involve the roots of multiple teeth. Thankfully, the other teeth were still vital and did not need treatment. So we're going to go through a few more articles here just to talk about cysts. This one is from 1998 from the IEJ, looks at different types of true cysts versus pocket cysts, if you remember learning about that when studying for boards. And really, I tell my patients that there are 2 types of things that we have to worry about. The first one is a granuloma. That one is a liquid. We get inside there, remove the source of the infection by starting the root canal, drain it, and your own body is able to take care of the problem and you don't have any issues and it heals up on its own. Sometimes though, that fluid is lined in a sac and we have to go in and surgically remove those. That would be what we would call a cyst. And so anytime I see something that's large like this, I'm always going to talk to the patient about this at the initial visit, that we will do everything we can to try to do this non-surgically, but as the size increases and as the number of teeth that it involves increases, there is a higher chance of needing a apico on these cases. We'll go through a few more articles here. Binary decision trees for preoperative periapical cyst screening using CBCT. The result of this one is that if the lesion volume exceeded 247 millimeters cubed, it's a way to discriminate between cyst and granulomas. In case you're wondering, 3,000 is more than 247. When we look at the prognosis of these teeth, this is an older study from back in 2004, but the findings here were that non-surgical root canal treatment using calcium hydroxide in teeth with cyst-like large periapical lesions containing cholesterol crystals can be an alternative treatment to surgical therapy. Said another way, one of the ways you can test for the presence of the cyst is by using calcium hydroxide as an inter-appointment medicament, because if it is healed and you're able to get it dry after that time, it has a high chance of not having to have a surgery. But if you still have drainage or issues with swelling or like the sinus tract being present, then you know that a surgery is probably going to be your only option there. A few more studies to go over here. Correlation of radiographic size and presence of radiographic lamina with histological findings in 70 periapical lesions. This is from 2008 from the oral surgeons. What they find is that there was not an association between the size or whether or not there was a lamina alone to determine if the lesion was a cyst or a granuloma. So if we actually look at the data from that 2023 study, I thought this was interesting, kind of the general information. You see that there's a much higher incidence of just these lesions in general in the anterior maxilla, 63 versus 20 in the rest of the entire mouth. We do see that it has a much higher incisor delineation, in this case 65, and the rest are 18. And curiously enough, I do see an increase in female. I don't know if this is because of their population sample that they took, but I haven't seen anything in the past about there being a higher incidence of females with these lesions. When we look at the relative risk ratio of a tooth having a cyst compared to a granuloma, the 2 that I wanted to show you is that the size of the lesion does have a relative risk ratio of 3, which is pretty decent. The problem is the p-value is kind of not ideal, and that's because your confidence interval is all over the place there. Look at though with tooth involvement, 6 times relative risk ratio. Everyone would be happy with that p-value, and you can see that confidence interval goes very, very high on this one. It's the only one that actually is over 1. So we do know that that shows we have a higher risk if it's multiple teeth. Said another way, we still don't know. Our literature base is kind of garbage. I ended up doing this in 2 different visits. During the interim, we'll talk about that. It turns out that they're leaving the country permanently, so they will not be coming back here. Normally this is a case where I might try to do some different things, but because of the time restrictions, I thought this was a good one to go through. All right, to go ahead and start off, we're going to be cutting through that PFM crown. Very straightforward one here. You guys have all seen these before. Remove with a diamond, then go with a metal cutting burr. Access with a workhorse. It's pretty straightforward. I have a specific video on accessing different types of crowns that you can review if you need that. I did cut out some of the actual root canal portion. I feel like most of the viewers here have seen it through other videos, and I really wanted to get to the good part, which is the actual surgery. So I know that there are probably a few weirdos out there who would want to have an hour-and-a-half long video. I love you and I see you, but I don't want to talk that much either. So this is long enough at 40 minutes. Great shot there with all that pus coming out. As soon as we dropped in, we saw a lot of drainage. And so on a case like this, I'm going to be using a larger file to begin with, just because the patient was young. And so the natural size of the canal is such that a F1 is going to be a better shape just to fit there. I could put a 2006 in there. I could put a 17, but it's not going to make a difference and it's not going to touch anything. So it really, I definitely tend towards the more conservative side when it comes to file size choice. But on an anterior case like this, I'm more likely to move to something more in the Pro Taper series, just because the natural taper of those canals matches the file a lot better. So that's what we're doing here. Poor man's gentle wave, getting that suction in there. And some of you might be asking, why didn't I use the gentle wave here? And that definitely is a consideration here. I found for anteriors, it doesn't really do that great of drying everything out. For molars, it's an absolute godsend. Absolutely love it. But for a lot of the anterior cases where I thought we could be able to, make a difference here, I still usually have to end up going towards the surgery, and I still would be doing the calcium hydroxide. So no need to waste the patient's time and, the cost of running a cycle if I don't think it's going to do anything. So lots of rinsing here, just getting as much, antibacterial stuff inside there. I could run 30 cc's of bleach through the tooth, but really the calcium hydroxide is what's going to do the difference here. So we're going to dry. You can see there is still some drainage. That's definitely a sign that there's stuff going on at the apex. And you'll definitely see when I use the paper points, as I'm tapping them against the rubber dam to see if we still have drainage, they're all bending at the tip. That tells us that there is still an infection inside there, which we totally should have expected at this point. So I will be using calcium hydroxide. All right, so I talked to the patient while we were doing this, and she was a little bit anxious. Now, when you have this large infection, sometimes I will convince them to just kind of push forward, and that's what she was able to do. With the IND, it is a little tough, obviously. Now, we did bring her back on Halcyon for the future appointments, but anytime you're dealing with an IND, it's always fun. Nothing too crazy there. Cavit to clean that off, and then we will be doing the IND here. So as far as the incision and drainage goes, sometimes you don't have to do it, but as far as how you do it, pretty much just go in with the 15 and boom, you can see the massive amount of drainage. Let's do that slow-mo. Oh yeah, you can see it already starting to drain, and then boom. Just go, you gotta love the, we're all sickos. I know there are a bunch of you out there right now who are very excited by this video, and I love all of you. So as far as the IND, I just wanted to get some oxygen in there, get that drainage out. She was swollen. She had started antibiotics the day before, but they clearly hadn't kicked in. And in this case, my whole goal was just to get the junk out of there. So this brings us to our next kind of mini lit review, which is what is the outcome on actually doing IND? Funny enough, the lead author is my friend and fellow endodontist in town, Hannah. So shout out to Hannah. I believe this is your thesis out of The Ohio State University. So well done on a great study. In the background to her paper, she points out that there is a lot of recommendations, but not necessarily with any data backing it. So for example, Pathways of the Pulp says that it's indicated for any fluctuant periradicular swelling, and it provides prompt improvement of the clinical signs and symptoms. They also say that you should drain in any case with cellulitis because it will help kind of introduce oxygen, which can reduce the number of anaerobic bacteria. This is what I've always also taught. The problem is there's really actually no studies done on that. And if we look at the hospital literature for our physician colleagues, they also find that there's not really a lot of evidence showing that INDs work for cutaneous swellings. Now, obviously in cases like Ludwig's angina, places where the patient's going to be in danger, you definitely need to get some drainage in there to remove the pressure. But it's a big fat, well, we don't really know what is necessary. At the conclusion of her study, she actually found that patients who received a mock procedure had better pain relief than patients who actually had the IND with the drain placement. The reason I bring this up is because I still wanted to do this because on a case like this where you have that large infection, you can make your life easier when you do the surgery by reducing the size of the hole inside the bone. And there's a few different ways to do that. So this study looked at decompression as a treatment for jaw cysts, and there are a few different ways we can treat cysts to reduce the size to make it so that the healing process is more predictable. You can do decompression, you can do marsupialization, which is a cool procedure named after kangaroos. You can do enucleation, which is removing the entire cyst, and you can resect bone. As it goes farther down, you do create more trauma to the area. And what they found in this study is that decompression could be performed as a procedure either in one section or combined with subsequent enucleation, but that they do recommend enucleating any OKCs, and they did find that there were less complications with decompression. So in a case like this, I'm not necessarily trying to drain it so she has less pain or heals up. I'm trying to create some space so that the cyst would hopefully have a lower chance of sticking around. Let's go ahead and fast forward a month and she comes back. At this point, she has told me, hey, I am moving out of the country in a month, so we don't have a chance to do something like a traditional end step with calcium hydroxide, try to keep doing the decompression. So at this point, my hands are kind of tied, and I do end up deciding to go for the pack and whack. Fun term there.
Shake and bake.
So let's go ahead and watch how we do that process. As far as reaccessing the tooth, everyone knows how to do this. Workhorse burr back through the cavit, pretty straightforward here. Recapitulate with a 20K file back down to length, make sure there's nothing wrong here. It's an anterior tooth. These are pretty easy to do as far as the root canal, so I sped up a lot of this because you've all seen this before. Final rinsing here just until I can see everything nice and clean. Same thing, activate, EDTA, we'll come back and activate again, and then we'll finish up here with isopropyl alcohol to help dry everything. When we get inside there, I'm going to use that little microsuction, and you can see there is still a decent amount of drainage here, and when I go in with the paper points, same thing. This is not unexpected. With the size of this, I did suspect that there would be a cyst here. We had already talked about it. We already planned for it. My main goal is to get most of the canal as dry as possible so I can predictably fill the case. You saw there that as we got farther down, there was still some more drainage in this area. So I'm going to use that microsuction to try to get it as dry as possible. And that was enough that even though there is still a little weepage at the apex, I'm about to cut that off in about 5 minutes anyway. So it's okay if we don't get perfectly dry at the apex in these cases, and you just use the squirt fill. This is one where I'm not worried about overfills either because I'm about to go cut it off anyway. So get that thing down packed nicely, and then I'll end up doing the restorative for this dentist as well. Rinse with isopropyl alcohol to get the sealer off, dry it, and then we should be ready to do the post. So for the post space, I'm going to use the B&L Alpha to make my actual space for this using the 4504 tip, which should fit my 5004 cone very nicely. I was nice and cut out about 5 minutes of me messing around with this one piece of gutta percha that just did not want to get out from under that lingual horn, but we I promise you, it looks good in the end. So I cut that out. Here's the video with the picture with the actual post. Take an x-ray, make sure that looks good. It looked rock solid as far as the seal there, and we're going to be ready to seal it up. Now, I did want to make sure we measured it so that everything looks good. Make sure you're checking your things along the way to make sure that the measurements are proper for what you want to do. And do remember, you're going to cut some of the root off, so that's going to change your number. I did use hydrofluoric acid etch. I just wanted to show that there's slow speed, so I did do that, but I don't think you need to see it sitting there for that amount of time. BioClear disclosing solution, come in with the blaster. Once again, this part is pretty straightforward. You all know how the root canal goes. Want to make sure we get a good seal on this tooth. I do believe she will get this crown eventually replaced. Aesthetically, it's not the prettiest, but right now I just needed to get her something that will be stable so she can get on to her new life in the different country and go from there. You did see I would admit that now after there's a recent comment on one of my videos about using total etch with self-etching primers, and you're totally correct. I'm always trying to learn new things. I just got last Friday when I'm recording this, but I went to an all-day CE with Nate Lawson out of Alabama, and he kind of went through all the different the bonding ideas, and so it was a great one to remember, like, oh, we don't actually have to do this here. The new self-etching is good enough. So that's a case where now if I were doing, this case is probably 2 months old, but I would not be doing total etch in that case. Now, we are going to be using the Luxacor dual cure buildup material. I'm going to use opaque here because it does have that metal on the back, so it hides it a little bit better. It's a trick you can do if, most people aren't looking on the, in linguals or palatals of their incisors, but if you can make it look whiter, people are always happy with that. Place the post inside there, bond it in, smooth it off with a glick. It's pretty straightforward. Once again, it's an anterior tooth. You all know how this goes. So we are about to go into the real fun part, which will be the apico. But before we do that, final light cure, get that all sealed up. polish it up, check the bite, which I did off camera, and then we'll get ready to do the actual apico. So if you have any questions about this part, I have plenty of videos on anteriors, but let's go to the apico. So there's your time. I know a lot of people like looking at those. First visit was 8 minutes and 2 seconds to open and med. Second visit, I think I probably spent like 7 minutes just getting that stupid gutta percha out of that one spot. So you're welcome for not showing my the struggle. That's definitely real there. So at this point, I have re-anesthetized her with the 1 to 50 epi. We are set up. They're switched over the room, so that does take a few minutes to just switch everything over. It's a great time for the patient to go to the bathroom if need be. But at this point, we're going to go ahead and move forward with the apico. So we start with the apico. I've already checked her attached gingiva. It's very healthy, and so we're going to do an attached gingival incision here because she had a low smile line. I didn't want to have any recession in this area. Her tooth was also long enough, and she had a nice bony collar around the coronal aspect that I didn't think that we would need to have a full thickness because the lesion was very much at the apex of this tooth. I did do a vertical incision on the distal there just because I knew this was a long tooth, 24 millimeters long, and so I needed to have a little extra space there. But just using the periosteal elevator, pulling everything back, and you'll see here in a second the size of this lesion. It's quite impressive. Notice, though, that I had to go a little bit higher. Once again, really long tooth. Those apicos on longer teeth do make it a little bit more difficult, especially when you need to get a huge amount of the lesion out. So you can kind of see the suction getting some of the liquid there as I am dropping into the lesion. And that right there, as we peel it off, that's the start of it right there at the very bottom of your screen. Now, she did have a frenum right here that was kind of in my way, so I ended up cutting around it. I found that it's better to excise it like this rather than cut through it. It allows you to be able to still get some traction on the sutures when you're going in, whereas if you cut through it, it's not great tissue and it tends to rip and it can be kind of a mess post-operatively. So here's a quick tip for you. By the way, this is not cut at all. So the only cuts I did on here were specifically for stabilization. So all these are, this is exactly as long as it takes. I've had a few friends recently ask me for a more updated apico video just to kind of show the efficiency in there. And really the key is just kind of focus on what you need to do and move to the next step. Don't I think a lot of us like to think of every little possible thing we could be doing. And really, it's pretty straightforward when you think about it. Root canal is, or an apico is, you flap it. Also, look at the size of that thing. It was absolutely massive. Way, way bigger than I expected. So huge cyst inside this tooth. Ended up sending this one off for biopsy. You'll see the assistant grab it there in just a second. And turns out it was a odontogenic cyst. No surprise there. So it should heal up beautifully. But as I was saying, for efficiency with apicos, it's really important to remember you don't want to keep them. The longer you keep them flapped open, the worse it is. So there's a few keys that can kind of help. Remember that bone does grow back. I'm a big advocate for making small holes inside teeth. However, it is okay if you need to make a slightly larger hole in the bone because the bone does grow back. Be careful, obviously, don't do anything stupid. But don't feel like you have to work through these microscopic holes just because you have a microscope. And same thing with the flap. You can make it a little bit larger if you need to. The gum tissue will grow back. Obviously, think about the aesthetics, think about kind of the other complications that can occur. But for most patients, I find that they do just fine even if you have a more, let's say, traditional apico rather than a microsurgical one here. What we're going to do now is cut off the root of that tooth, and I love this Blade Sonic from Halsey. It's an absolutely wonderful ultrasonic. I can link it down in the description below, but I really don't use Lindemann burrs at all anymore for resecting teeth. This is just so much easier. It gives you a nice, super clean cut. It's not rough. It's has more control. There's water. Like, I can't say enough good things about it. You just crank it up to maximum. You can see there was a little bit of extrusion at gutta percha as expected because I would never squirt fill this case if I was going to finish it normally, but I knew I was doing an apico, so it didn't really matter if we extruded some gutta percha. At this point, we have removed enough of the tip that it's really, most of this I think is more the cyst rather than doing that 3 millimeters. I was probably at 2 to 3, and that should be good enough. But this is another trick. If you don't have this in your surgery kit, this is just a regular curette like you'd use to clean teeth. It works very well for grabbing bits of the lesion that are palatal to the root. You can see just how large the actual hole inside the bone is here. And by using the curette, it can actually get around there and pull out the tissue very, very effectively. And that's what you're seeing me do here. Just want to get this all cleaned out. there have been studies showing, you don't have to remove all of the lesion. There's no doubt about that. But there also have been some things saying, if you don't remove it all, you do have a higher risk of recurrence here. So I do want to get as much out as reasonable, but I'm not going to be like drilling into the bone to remove any remnants. Her body she's young. She should heal up really well. You did see the bone was a little bit soft and denuded right up at that top there. I do see this with these really large infections. It kind of starts to affect it, but because it's still covering the root so well, I don't want to remove that because you would definitely risk recession at that point. All right, so we got most of the lesion out. You can see just the size of that hole, and there's still stuff coming out. That's this one. I think my staff and I were just like astounded by how large this actual hole was. But right there is the gutta percha. So we'll start off. I like using the B&L Bio. Their Retropreparation ultrasonics are great because instead of being made out of diamonds, they have like these little carbide projections. So when you start to pull out after activating it, it'll kind of melt the gutta percha and grab onto it. And it is very easy then you can see I'm pulling out the actual gutta percha. It makes it very predictable to get the gutta percha out. And that's one of the most annoying parts with doing retro preps is actually getting the gutta percha out the sides of the wall. You can usually go straight down it. It's along the walls of the actual canal where it's a little bit harder to remove. And so you can see me kind of pecking and then using that pulling motion. And that's where this is a really nice ultrasonic for that. I've used pretty much every type of ultrasonic you can think of for doing apicos, and I have like 15 different ones that I use. So this is not, with all surgery stuff, I recommend just getting a smorgasbord of stuff that you think you might want to try. I usually tend to use the same few things, but you don't want to be all of a sudden looking for a procedure or for an instrument when you're mid-surgery. So this is one of the kits that is definitely not as efficient or streamlined as it could be, but that's on purpose because I don't want to have to get up and go find something while we're working on a patient. These retro mirrors are really useful as well to be able to see and just kind of visualize, is there any gutta percha? Do we get everything out? How does it look? So these are really nice. And pro tip here, you can use the Mirror Magic stuff that I've talked about in the past with these, and it makes a really, look at how nice and clean that is. So I rubbed off the blood and stuff that was on the mirror itself, and the Mirror Magic does a really nice job creating this hydrophobic surface that resists the condensation of air and humidity and makes it a lot easier to see. So in that case, you can see we're looking pretty good. There is some bleeding inside there, which isn't to be not surprising. As we dry it out, though, I was able to get a pretty good visualization, and it looks good enough to go ahead and take an x-ray at this point. Now, when I did take the x-ray, I wasn't pleased. I wanted to remove just a little bit more here, so I did cut out the x-ray one. You guys don't need to see the patient just sitting there for a minute while I take an x-ray. But I did want to remove just a little bit more. We didn't have quite, it was only about 1 millimeter or 2, and I wanted to go closer to the 3 millimeter mark. I also didn't remove as much of the tip of it, but you can see how much that tooth is moving. That plus her leaving the country made me kind of lean more towards doing an actual bone graft. So sneak peek, we will do a bone graft in this case here. We'll go through the literature base for that as well. There are some studies showing you don't have to. There's some showing that it helps. There's some showing that you have to do it for through and throughs. There's a bunch of different ways of considering it. In my case, though, given her situation that she was leaving, we didn't have any more time with her, I wanted to try to stack the deck in her favor. And by putting the bone in there, it should give her a little bit more periodontal support. And God forbid something were to happen, now instead of having a huge kind of defect in this area, at least it has a better chance of healing nicely. So if an implant were to be necessary, you wouldn't have to do a subsequent graft after that. So at this point, we took another x-ray. It looks really good for the ultrasonic. So we're going to start. Is that what I'm doing actually? Should I go back in? This is what happens when you try to do this in one take. This is a 40-minute video, you guys. I'm trying to do this in one take. There were definitely a few cuts that will be made, but I am actually recording it once, so hopefully the audio issues won't be as present as they were in the last one, switching between different days. But I had a little bit of time at the end of the day, so I was like, okay, I got 40 minutes. I'm going to talk for a very long time about how to do an apico. All right, so we all are learning together. I still had to remove more, and that's what we're doing. Oh, I should stop doing these at the end of the day. I tend to get a little more punch drunk. There you can see a little bit more of the gutta percha coming out of there, but I just want to make sure it looks as good as possible. You can also just very gently, if you haven't done this before, if there's a little stuff on the outside of the tooth, you can actually rub it, the ultrasonic on the outside of the tooth, and it will get some of that lesion stuff off. So kind of a fun way to, if you haven't tried that before, be gentle. I'm only running I run the Retroprep at like 50% power because they break if you go over that for sure. And so it's not going to damage the tooth or anything like that, but it can make a difference getting those little pieces off. And you see me coming back in with the curette there, just making sure that we get this as clean as possible because this was a pretty big infection. I want to give this tooth the best possible chance of success. All right, so we're going to go ahead and rinse everything out, keep looking and making sure we got as much of the lesion out and that the Retroprep's stable. This is one where I took a little bit more time on removing the extent of the cyst just because of the size here. And then I did need to go back and do the Retroprep a little bit more. So from an efficiency standpoint, I probably could have been maybe a little bit faster, but the total Apico time was only 30 minutes from start to finish, including suturing. So not, terrible here. And at this point, I should mention that this was done without my main assistant who does my surgeries. So I am also teaching. So that will slow down the speed as I have to tell the assistants what we need next rather than just having it handed to me. That's the one problem with teaching assistants how to do surgery is if you don't do it very often, it's tough for them to get the reps to actually, get this down. My main assistant, Jenny, has been with me for 10 years, so I sent her on a cruise as a thank you. This was in October, and we had like 2 Apicos that week, so the staff was very stressed out of, oh God, we now have to actually go in and learn how to do an Apico, but they did a fantastic job. You'll see a little struggle with the suturing, but that is every time you try to train a surgical assistant, that's very normal. So don't be surprised if you have to do a little bit more work there, but very proud of what they did with this. But you will notice it is a little bit slower than normal. It's still a good job. I mean, 30 minutes for an Apico is pretty darn good, I think, with the bone graft and suturing everything. I call that pretty good, but I usually try to keep these under 30 minutes just because I don't want them to be open for that long. It just runs the risk of complications, infections, things like that. So at this point, we've shoved all the bracelets. I think I actually shoved in all the bracelets that they took out. That's how many it is. And I didn't need to fill everything. I'm mostly just wanting to make sure we don't have any leakage from the crypt. The assistant can handle any small bleeding spots from the bone, the gingiva, things like that in the meantime. But I want to make sure that we don't have any leakage from the crypt because when it comes time to actually do the Retroprep, I need to make sure that it's going to be nice and dry, even with the BC putty stuff. And what they're doing right now is I'm just pretty much coaching them on how to pass instruments, how to pass the putty. This is one thing I do with six-handed dentistry. So I have one assistant who's sitting next to me, and they are in charge of suction and kind of retraction if I need it. And then I have the other assistant, and they actually stand next to the patient, so in front of me, and they hand me the BC putty as well as the retro plugger. And it makes it very efficient. That way they're not in each other's way, and I can make sure that we have a really nice dry field. And this has been 30, 45 seconds now of me just talking. And you can see those bracelets are doing a wonderful job keeping this nice and dry. There's no blood going anywhere near this, even as the assistants are taking their sweet time putting everything together. I think at one point I had to help them with it. It's fine. It does take a little bit of time to train them, but I probably should have cut this out. But I just want to show you that sometimes real world endo is different than what you see on the internet. So sometimes you got to stick around and wait for your assistants to do things as they're learning. So at this point, though, we are ready. They have finally got it. They did give it to me upside down, and that's the wrong instrument, but it's okay. I will make it work. Nothing like using a half Holland back to do an Apico. Anyway, that's the BC putty, the root repair material. Absolutely love this stuff. It's really nice because you can shape it, and we did have to work on shaping this at a different look. You can see they kind of just smush it on there like Cavit, but you can shape it almost like a triangle, and it goes in and fills up this area very, very efficiently and very well. It's one of my favorite materials. I don't even own MTA anymore because I use this stuff. Now, is it 5 times the cost? You bet it is. It expires quickly, and it's a pain in the ass, but it works incredibly well. And for me, who is using it on the regular basis to deal with, perforations, not my own, don't worry, and apicos and things like that, or direct pulp caps, it is worth having around. So I think I'm just still waiting on them to pass stuff back and forth. Once again, this is fun. This is the real world endo that we talked about. Definitely should have sped this up. Anyway, what the idea is you place the BC putty, then go in with your retro plugger, and then come in with another layer of BC putty just to make sure you get a nice solid dense seal. And this stuff, you do have to be careful. If you've used the MTA in the past, you'll know that you can actually compact it pretty tightly. Same thing like if you were old school enough to have done amalgam retrofills, you can totally compact it because it's amalgam. This stuff is a little bit softer. So when you are doing your retro prep here, you have to be a little more gentle. And I'm almost letting the material itself tell me as it's getting close because I don't want to create a divot inside there. So don't push quite as hard as you would for, say, amalgam or old school MTA. But once you get down to this point where you just have that like last remaining millimeter of BC to go and the space in the retro prep, I like to take a dry cotton pellet and just wipe off the excess. It actually works really well to create a really smooth, flat surface and makes it so I don't have to go back in and remove any, excess BC. It's not going to affect the success, but it does look sloppy on the x-ray. So I don't want to leave that inside there. You can watch as I'm just removing racelet after racelet after racelet. Oh, by the way, make sure you count these. The worst possible day is when you realize that you've left something inside a person. So yeah, I thankfully, knock on wood, have not done that, but I have been counting racelets ever since I started doing Apicoes. I make sure the assistant counts it. She makes sure that all of they are accounted for before we suture up anything, because you don't want to leave that inside a human, obviously. There was a little bit of excessive BC on the outside of the tooth, on the distal there, so you can see me coming in with our trusty curette. There you go, getting that last piece off there. You can rinse this area out. However, I have found that you have to be really gentle here. So you can see I'm rinsing mostly the crypt just to make sure it's looking solid. But I don't really want to rinse directly on the putty. It does take a significant amount of time to set to complete hardness. So as long as you stay, roughly away, a few millimeters away from it, you're not going to be too bad. But at this point, I am going to be doing the bone graft. We talked about it because of the situation here. I ended up using, I think actually more than a CC. I know that says a CC. I can't remember. I can actually look at the chart. I'll put it here how much I use because we put that in the chart. But I ended up using quite a lot of bone graft material just due to the size of this. I want this thing to be nice and stable. And so that's what you see me doing here is just that bone graft procedure. Pretty straightforward. I have this, it's like the back end of the 9, and it actually works extremely well for bone grafting. I know they make very expensive, cool toys that periodontists and oral surgeons love, but this, for the few bone grafts that I do a year, works totally well. If you have the ability to share bone with an oral surgeon like I do, it works really well because the stuff does expire and it's extremely expensive. So what I did is when we opened the office together, I bought Chris 5 packets of 1cc of bone graft. And we just keep track, and he uses it all up, and he just has a big supply here. And then anytime I use them, I just check off 1. And once I've used up 5, I buy him another bit. You can also do this for lesser used things like green Lido or carbocaine. If you know that it's going to expire, see if you can find a dentist in town that you can kind of share with. It does make it a lot, like for a while there, I was sharing the carbocaine with the dentist next door. I'd buy a pack and then he'd buy a pack as we go through, and it would always expire before we actually used it all. So it's a way to make your losses just a little bit less because you don't want to have stuff expire. That kind of sucks. This is a trick. I think I have shown this in a previous video, but you can use tissue forceps to help hold the flap in place. And I like to take a 2x2 and actually put pressure right at the upper corner where I'm going to make my first stitch. This is a nice way to get a little fibrin clot, and it holds the gingiva and the flap in place a little bit better. So this whole time I'm putting quite a fair amount of pressure on here. I want to create that nice clot. I want to create some hemostasis. And this is a trick I actually learned from Jared Buck like 10 years ago, but it's a really nice way to get some stability before you start going in and doing your sutures. So when we come in here, you can see, well, that didn't work, but sometimes it makes a difference. It at least helps a little bit with your hemostasis. And the first thing I am going to do is go straight through that frenum, reattach that there. And you can see I took a very healthy bite. Frenums are that nasty type 1 collagen that just does not want to behave. And so you need to protect your work here and I'm going to do interrupted here. I'm going to make this as strong as possible. The other thing we've talked about in the past, and this is where the staff was frantically trying to figure out how to make it, my assistant Jenny came up with this kind of like dabber, I guess is the best way to describe it. And you can see it's a piece of 2x2. There's a couple of them that she's folded over. And what that allows her to do is come in and push and create some stability there as well. I often talk about being, very frugal when it comes to using different things, but one thing I hate more than anything in the world is chromic gut. I know a lot of people would use it here. I am a diva when it comes to sutures. I will say that. These are 6.0 Vicryl. These are very expensive, but it's worth it for me because even the smell of chromic guts gives me flashbacks to being in oral surgery. So I can't stand it. But one of the things that is a little bit frustrating about Vicryl is because it's so smooth and it's so small, you tend to have a higher risk of it unraveling on you if you don't create that initial clot. So what happens is when the assistant's coming in there with the little dabber, what that does is just as I created pressure in that corner after using the tissue forceps, this is going to create a little pressure, help with hemostasis, but it also creates kind of a little clot on the knot itself and holds it in place much better than if I were to try to just very quickly tie it all in. So if you haven't taught your assistants this trick yet, right now the assistant has, I think in one hand they have the dabber, they have scissors, and then we switch back and forth between holding the Minnesota. And then I have usually the Minnesota and then the actual needle itself because you have to reposition it. So you'll see me, it's tough to tell. I think this is, you might be able to actually see, my hands are green in this one. I think she uses the blue ones here. So you might be able to see when it switches, but I will go back and forth and actually have the assistants hold the Minnesota for part of it if I need to, reposition whatever it may be. And you can see that when I drop down, it's just to so I'm still holding all this. But for training purposes, this is one of the harder things to do. If you've talked to any periodontist, oral surgeon, anyone who does a lot of surgeries, getting your staff to kind of understand your nuances and how you want things to be, especially on a procedure you don't do quite as often, can be a little bit more difficult. So at this point, we got the main running locking suture going through. I did do a nice aggressive running locking suture here. I find that these work really well with these attached gingival flaps. Not sure how that little piece of cotton ball got in there, but thankfully she grabbed that. I think it was attached to my glove. I don't know. Regardless, you don't want to leave that, so I'm happy she grabbed it. But I will try to build this up for success. So when I'm doing suturing in cases like this, especially with a graft where I want it to make sure we have closure in here, I will usually start off by doing a nice long running locking just to get everything tight and get it, start of the process of closing everything up. And then I will go back in and as needed, put in single interrupteds to make sure we don't have any leakage. The nice part about this is rather than doing a bunch of single interrupteds, it is a lot faster, but it also kind of holds the tissue in place. So you can see we do have some gaps there that I will be needing to address, no doubt about that. But it's much easier to address those now that everything's in place rather than trying to do a bunch of singles. So that's kind of my thought process as far as suturing goes. I've seen people online and who do absolutely artistic sutures. I was trained by oral surgeons, if you can't tell by everything about me. That's why I always have to apologize to the periodontists for some of the stuff that I do. If Nate's watching this, he's probably cringing right now. That would be my guess. Comment below or just text me if so. But you can see there are some gaps there. And that's okay. That's why I knew I was going to come back in anyway, further reinforce these, get a nice deep bite here, especially right over where that graft is, because we just spent a lot of money on this grafting material. I want it to work. Another thing as far as grafts, the question is whether or not you need to do a membrane. So just as a reminder, the whole reason we do a graft in the first place is because soft tissue grows a whole lot faster than bone. So by placing bone in there, you make a physical barrier that the soft tissue can't go into, and it furthers the chance that you're going to have a nice solid seal. Here, I'm not trying to build bone. I'm not trying to create space for an implant. I just want to recreate what was lost in the first place. So a membrane isn't really going to make a huge difference for me. The periosteum is actually going to act as the membrane and shouldn't really invade more than that. If, however, this were to be like an implant grafting, then that's when you would want to use something like a membrane because you're going to overfill with the bone. So for most apicos, we will go into some studies at the end, they showed that a membrane alone certainly isn't enough, and that the membrane plus the bone graft doesn't really have a huge difference compared to just the bone graft. So that's kind of my thought process of doing just the bone graft here. And, could this have healed up on its own? Maybe. there's not real great literature when it comes to apicos and bone grafts. We know that the small and medium-sized lesions, which aren't defined, by the way, tend to heal if they're okay. We know through and throughs do not heal. So those are cases where I will do bone grafts all the time. If it has exposed through to the palatal, on those cases, I will do bone grafts. But after talking with a few of the periodontists, it seems to be that if it's excessively large, or if I'm concerned that an implant might be necessary one day, it's probably worth it just to do the bone graft. I don't charge them much. I charge them like a little bit more than the cost because it's not, this is not a moneymaker for me. This is the root canal and apico I made more than enough on for, a tooth like this. It's more, I just want to make sure this tooth has the best possible chance of success. And so I think I gave her like just cost for the bone and called it a day. But you want to make sure that this is successful here. And so if you take the excessive cut, because I've seen people charge like $1,000 for grafts and apicos, which is absolutely insane to me. I think I charged her like $150 and called it a day. And but if you haven't, good pull through there. That's I did when you don't have a staff member who knows how to cut, they haven't done the sutures yet. Sometimes they'll cut a little bit high. And so my long suture tails now are becoming much, much smaller. So you'll get to see me mess around with, an inch left of tail here at the end to try to get everything working. We do get it to work, I promise. But you can see how this is kind of a combo where I'm doing the running locking to hold it initially and then individual sutures here. Suturing is definitely more of an art than a science, and there are many, many different opinions on here. Some of you may love this, some of you may hate this. The most important part is that you get the tissue as close to as possible back to where it was, and then it's going to heal. I am not an implant surgeon. I don't do any of the aesthetic things like periodontists do. This is the only soft tissue stuff that I actually do, and so take that with a grain of salt. But the patient, we were able to see her week after for her follow-up, got the stitches out. Everything was healing really beautifully. Oh, to be 19 years old again and have everything just heal. And it works. So that's the nice part here. The other thing to remember when you are working with gingiva, this is a fun quote that I got from, I think it was Jeff Rouse, actually. I'm just been quoting him left and right. You'll notice in all those cases that periodontists show, they're all thick phenotypes. It's all nice, thick, attached gingiva, real healthy looking. You can do anything in those cases. It's the cases where it becomes really thin that all of a sudden you start to see recession, you start to see bone loss, problems like that. So keep that in mind when you're looking at the patient. That's why I felt okay going with the split thickness or the attached gingival flap design here, because she had such nice, healthy keratinized tissue. I wasn't worried about this, in the long term. So at this point, we're going to rinse it all off. This is another good trick to make sure you just, clean them up. You don't want it to be, looking bloody when they come out. But when you rinse it off, you'll be able to quickly see if there's any remaining bleeding points. And then I will also come in with a wet 2x2, wipe everything, and very gently pull the lip into traction. You don't want to you're not trying to get a full face photo or anything like that. What you're trying to do here is just put a little bit of force on your sutures and see how they respond. That's a great point because you can start to see if there's any little extra bleeding points, things like that could be leading you to have some problems or complications. And you want to test all of these before you let that patient go. Now, we have the same standard post-op that I think pretty much everybody does. Don't lift the lip, ice, that sort of thing, ibuprofen, Tylenol, blah, 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 blah. But even then, patients, as I'm currently having multiple sutures in my mouth from having the second round of SFOT, but that'll be a different video. The patients do dumb things. I did definitely eat more aggressive food than I should have, and Nate's going to probably listen to this and actually kill me after, so I probably shouldn't have said that, but it's okay. The sutures are all in. I sent him a photo today, and he says everything's looking healthy, so maybe that burrito was okay, but probably not. We do tell him soft foods. We do tell him, take it easy here. You don't want to pull anything off, because that can, if you rip out sutures, it's a horrible day. I had a patient many years ago who was he liked using dip, and I did a lower incisor surgery, and the day after he put this massive wad of tobacco down in there, and of course ripped out all of his sutures, and it was just an absolute mess to have to go back in and fix all of that. I had grafted it because it was such a large lesion. So there was like bone graft. It's an absolute mess. So be very adamant with the patients. Do not lift up the lip. Obviously, don't chew tobacco next to the actual suit. Some of the things we have to tell patients, I never thought we'd have to tell people. Like, the common sense is just dead. I think we can all agree upon that. But I'm also not the best patient, as Nate definitely knows. But that's okay. I have nice thick gingiva, so it should heal up, no problems. But the final little spot right there was just on the other side of the frenum. There was a little bit of bleeding there. I wasn't happy. I wanted to make sure that was nice and tight. So you can see sutures can take a little bit longer. With my other assistant, we probably would have shaved about 5-10 minutes off of this whole procedure just because of her comfort level and because she's used to doing this sort of thing. But still a decent, efficient procedure, I would say, to get all this done in, 30 minutes for the apico. It was 15 minutes for the pack part before the whack, and a very quick open and med with the IND on there. So all in all, the whole treatment time was under an hour, but it was over multiple visits, and she was definitely high on Halcyon for this final one here. So just doing a few final reinforcing sutures around that frenum. I want to make sure we don't have any issues. I did leave this tail here. That's another thing. If you are doing a running locking and you start near where you're going to end, don't cut that tail off because you can use it to grab one more stitch. And that's exactly what I'm doing here to make sure that that's nice and tight. We are definitely getting down towards the end of this silly suture. I was about ready to go grab another one, but we ended up getting everything nice and tight enough that it's going to be okay. So cut those off and we will be pretty much good to go. So without further ado, let's take a look at that final x-ray. Really pleased with this. You can see even with the bone graft, there's still a little bit of radiolucency in that one area. Like, once again, I did say 30 minutes for the treatment, but let's go ahead and review those literature that I talked about. This is the most recent one. This is October. This is literally less than a month old, which is impact of root end filling material type and the application of bone graft on healing of periapical tissues after endosurgery, a clinical randomized controlled trial. So this one was pretty interesting. They actually looked at using a material kind of like a BC putty versus the gold standard MTA, and they did show that there really wasn't a difference, maybe even a little bit higher success rate for the more modern ones. As far as the bone grafting, although the success rates were high regardless of bone grafting, larger lesions may require their addition to show similar results. They did only test the maxillary teeth, but as we've already gone over, those are kind of the most common ones anyway. And then just to do a few other studies, one more study here, effective regeneration techniques on periapical surgery with different protocols for different lesion types. This is from the oral surgeons again, back in 2015. And what we see here is that when they look at using bone replacements versus membrane versus the RT is the regeneration techniques, what the conclusion was, you can use bone replacement with membranes or just by themselves. However, membranes alone do not have any benefit here. They recommend using regenerative techniques for through and through lesions, which we already knew, and they did say large. So this is my way of just feeling a little more vindicated that it is worth doing. And once again, to show you that pre-op, you can see definitely a large lesion there. Really pleased with the final here. If she ever comes back to the country, I'll hopefully get a recall here. But thank you all so much for watching. These have been really fun to put together. Let me know if you like this version where we kind of go a little bit more into the literature. For those of you studying for boards, whatever it may be, hopefully this is helpful. I do read the literature often, and this is what I take everything from. I'm always trying to constantly be learning, but I find that not everybody's weird nerds like me and is always on PubMed. Anyway, thank you all so much for watching, and I will talk to you all next time.